Everybody, today we're going to go over some of the ADHD diagnostic criteria. We're going to chat about it, and I'd love to hear you guys' thoughts down in the comments about it. So let's jump right in. We got the DSM-5. This is not the DSM-5 text revision, the most up-to-date DSM. It didn't change anything in the DSM criteria, so I got the PDF for this one, so that's what we're looking at. Here we are, attention deficit slash hyperactivity disorder. So the diagnostic criteria includes a persistent pattern of inattention and/or hyperactivity, impulsivity that interferes with functioning or development as characterized by one and/or two. So the first section here is inattention. The second section is hyperactivity and impulsivity. So let's go through these real quick. For inattention, you need to have 6 or more of the following symptoms which have persisted for at least 6 months to a degree that is inconsistent with developmental level and that negatively impacts directly on social and academic occupational activities. The symptoms are not solely a manifestation of oppositional behavior, defiance, hostility, or failure to understand tasks or instructions for older adolescents and adults age 17 and older. Only 5 are required. And so the main reason for this in my teachings and understanding is that as you get older, you tend to control these ADHD symptoms better, right? You come up with strategies of inattention because, you have to fit into society, you have to get a job, you have to work in an office, whatever. So you need to learn to deal with these. So when you're older, it requires less. When you're younger, it requires one more criteria. Now, one thing about these criteria that's really interesting, and there's 10 points here. 10 points, and you got to hit 6 out of 10 if you're a kid. And if you're 17 or older, you got to hit 5 out of 10, half of these. So the really important thing to look at in these diagnostic criterias, attention to details or makes careless mistakes in schoolwork, work, or during other activities. Often has difficulty sustaining attention in tasks or play. During lectures, conversations, or lengthy reading are the examples that they give. Often does not seem to listen when spoken to directly. Mind seems elsewhere, even in the absence of any obvious distraction. Often does not follow through on instructions and fails to finish schoolwork, chores, or duties in the workplaces. Often has difficulty organizing tasks and activity, difficulty managing sequential tasks, difficulty keeping materials and belongings in order, messy, disorganized work, has poor time management, fails to meet deadlines, time management, right? Messy, disorganized work. Often avoids, dislikes, or is reluctant to engage in tasks that require sustained mental effort like schoolwork or homework. And for older adolescents, preparing reports, forms, reviewing lengthy papers. Often loses things necessary for tasks or activities. School materials, pencils, books, tools, wallet, keys, paperwork, eyeglasses, mobile telephones. And I don't know anybody who doesn't lose things at times. Subjective is an understatement. Is often easily distracted by extraneous stimuli. For older adolescents and adults may include unrelated thoughts. Is often forgetful in daily activities, doing chores, running errands for older adolescents and adults, returning calls, paying bills, keeping appointments. Okay, so what are the themes that we see? I'd love you if you pause the video and you think about some of the themes that you're seeing here. So let's go down to the hyperactivity and impulsivity part. 6 or more of the following symptoms have persisted for at least 6 months. Similar. Same things for older individuals, 5 or less. So same thing. And all you have to do is meet the criteria for either 1 and or 2, right? So, and then usually they used to call it ADD if you didn't have any of the hyperactivity. They don't call it ADD anymore. They just call it ADHD hyperactive or ADHD non-hyperactive, some nonsense like that. Okay, so what are the criteria? Often fidgets or taps hands or feet or squirms in seat. Often leaves seat in situations when remaining seated is expected. Leaves his or her place in the classroom, office, workplace, other situations that require remaining in place. Often runs about or climbs in situations where it is inappropriate. This may be feeling restless in adults, is often unable to play or engage in leisure activities quietly. Yes, because children should play and engage in leisure activities quietly. That's natural. Is often on the go, acting as if driven by a motor. Is often on the go, acting like you can see how unscientific this really is. Often talks excessively. So I'd like to know what excessive is. It also depends on your view of the individual. We'll return to that in a moment. Blurts out an answer before a question has been completed. Often has difficulty waiting his or her turn. Often interrupts or intrudes on others. So, several inattentive or hyperactive impulsive symptoms were present prior to age 12. That's important. They need to trace it back to age 12. And this is new to the DSM-5 because it used to go back, I think, to age 7. So you had to trace it back much further. They actually made it easier to give this diagnosis because all you got to do is remember what you were like when you were 12-year-old versus when you were 6 or 7 years old. So it was easier to give this diagnosis out to individuals. Several inattentive or hyperactive impulsive symptoms are present in two or more settings, so it needs to be done at home, school, or work with friends or relatives, or in other activities, right? So it needs to be consistent across the board, right? There's clear evidence that symptoms interfere with or reduce the quality of social, academic, or occupational functioning. And their symptoms do not occur exclusively during the course of schizophrenia or other psychotic disorders, whatever. So it just needs to make sure it's not a part of some other sort of disorder. But ADHD is the most common comorbid disorder. Often ADHD can get tacked on with pretty well any disorder. You see it with ODD, you see it especially with developmental disorders or neurodevelopmental disorders. So that's really important. So what are the things that I want to bring up here? Of course, this is subjective, right? Often talks excessively, very subjective. Often fidgets or taps hands with feet or squirms in seat. It's very subjective. All of this is very subjective. The other thing that I want to highlight is that often they reference schoolwork, work, or other activities, right? Lectures, conversations, or lengthy reading. So really what we're focused on here with ADHD is people being environments. They're in environments that are completely unnatural, like a school or an office. Or if it's other activities, perhaps the parents are putting them in the activities that children don't want to do. If a kid hates playing soccer and you force them to play soccer, well, do you think they're going to be attentive? Do you think they're going to be focused? Do you think they're going to be acting impulsively or hyperactive or distracted? So that's really, really important things to consider. Often talks excessively. That one is probably the funniest one because this also depends on the view of the individual. So if you're talking to somebody and you really enjoy their presence and you enjoy what they have to say and you find what they're saying very interesting, if they blab on for hours, you're not going to find that they talk excessively. I've had podcast guests on who may talk excessively, but I'm so interested and fascinated by the words that they're speaking that I don't view it as excessive. I like that they go on tangents. I enjoy when they go on and on about a subject in more and more detail and they give examples. So your view of what is excessive and what is not, like this is where the subjectivity comes in, right? But if you don't like an individual, say you don't like your kids, a lot of parents don't like their kids. First of all, that's one of the main problems we have. But if you don't like your kid or they annoy you, you're going to sit there and say, yeah, they talk excessively. Like they talk excessively. And that applies to more than this, right? Because, you're going to notice that someone's fidgeting or tapping their hands or feet if you find them annoying. The other thing is that, are we asking too much of these kids here? Like, unable to play or engage in leisure activities quietly. Why does a kid need to be quiet? Right? This is completely based on social norms. There is no objectivity here. It's based on social and cultural factors. This is an unscientific document, completely unscientific, backed by absolutely no science, of course, because all of these criteria are completely subjective. There's no way that you could tell me that this is objective in any respect. So the other thing that's important to highlight is that these need to be present in two or more settings. So it needs to be at home, at school, or at work, or other activities with friends, relatives, etc. That's also a really important point because the physician or the clinical psychologist or whoever's giving the diagnosis is not going to be present in two or more settings. It's not going to be present at home, at work, or at school, or with friends. So what does that individual who's giving the diagnosis have to go off of? What information do they have to go off of? They have to go off of the word of mouth from the parent. There may be a report from a therapist or a school teacher. There may be a report from a boss at work. And so then you can see, my previous point about what's the individual's view of the person who has this ADHD. If your boss doesn't like you, say you don't care about your job and so you don't do a good job. You don't work hard. You think your boss is going to like you? Are they going to say that you have difficulty meeting deadlines or you get sidetracked and you don't finish your work on time? You know, it depends on the view of the individual. So there's layers of subjectivity because first of all the individual giving the diagnosis is not going to be in the settings to give a objective view, right? So then you get the word of mouth from the teachers, the bosses, and the family members who may not enjoy having this kid around because this kid is active, right? Is this kid talks excessively? These are so pejorative. Children are children. They're not dogs. We're not supposed to make them obedient. We're supposed to allow them to explore. If they squirm in their seat and we tell them, sit down, you know, is that because the kid has some sort of disorder, or is it because maybe the kid shouldn't be forced to sit in a seat? One thing about ADHD is that once the kids go outside, it becomes much more tolerable and the symptoms tend to disappear, right? It's only intolerant because we're in the classroom in a small space. And so if a kid's being loud during play, God forbid, it's more intolerable. It's more, you get more annoyed. And then your view of that child is going to change, and you're going to think that there's something wrong with that child because maybe there are other children in the class who are more quiet and reserved and can play quietly, right? But this is personality type. This is personality type. This is not a mental disorder. And we certainly should not be medicating people for their personality types. And just because we do medicate people and these symptoms tend to disappear, doesn't mean that we're reducing symptoms from a disorder. It means that we're reducing the individual away from their personality. That's the reality of the situation. You're numbing them from their reality. All right, so you can see here, you can pause and read for the diagnostic features. We're sort of just rewriting what was told. ADHD always begins in childhood. That's a really important thing to understand. Associated features supporting diagnosis. There are other factors, delays in language, motor, social development. That's not specific to ADHD, of course, but they co-occur, right? So you often see ADHD get diagnosed alongside autism, um, and other disorders as well. ADHD can sort of be tacked on to any sort of problem kid in the classroom, and there's always a couple of them. The prevalence suggests that ADHD in most cultures is about 5% of children and 2.5% of adults, which is very interesting because it seems to be, based on these numbers, that kids grow out of ADHD. Interesting. Should we medicate that, or is it just a part of their development? Or is it a neurodevelopmental disorder? Risk and prognostic factors. ADHD is associated with reduced behavioral inhibition, effortful control, or constraint, negative emotionality, and or elevated novelty seeking. These traits may predispose some children to ADHD, but not specific to the order. Elevated novelty seeking is really interesting because, personally, just off the top of my head, and we can certainly delve more into this if you guys are interested, elevated novelty seeking, I would say, is completely correlated with the amount of dopamine intake of the individual, of the child. If you're constantly scrolling on social media and TikTok and playing Fortnite and Minecraft and whatever, you constantly need to seek something new to get that same dopamine hit that you're constantly changing, right? So that's a really important thing. Very low birth weight, that's an interesting environmental factor. But most children with low birth weight do not develop ADHD. It's interesting that this is in here. Correlated with smoking during pregnancy. I'm sure there's a lot of other things. Minority of cases may be related to reactions to aspect of diet. Now, this is really interesting too. There may be cases where it is diet related, and there may be cases where it is related to neurotoxin exposure, like lead, infections, encephalitis, which would also go back to heavy metals if, in our understanding, because bacteria don't cause disease or any sort of pathogen. Alcohol exposure in utero, that's really interesting. Other things that are really important: history of child abuse, neglect, foster placements. These certainly give um, children a rough go. That is really difficult for a child to go through. It's likely that if they have undergone some sort of trauma, of that severity, such as child abuse, neglect, or foster placements, ADHD is not going to be their main problem. It's not going to be, they can't sit still in the classroom. The children have severe trauma that they need to deal with. And I think that's really important to understand. So, genetic and physiological factors, um, we know that heritability studies are trash and garbage, and we'll go over them more in the future. Epigenetics sort of throws this all out the window. It's environmental. If you're going to talk about genetics, it's environmental. You can have genetic predisposition and not get the disorder. It's based on the environment. Yeah, ADHD is more frequent in males than females. Again, that's really interesting. Consequences. You can read through that if you'd like. Now, here's the really interesting one. This is another category: unspecified attention deficit slash hyperactivity disorder. This category applies to presentations in which symptoms characteristic of attention deficit hyperactivity disorder that cause clinically significant distress or impairment in social, occupational, or other important areas of functioning predominate but do not meet the full criteria for ADHD or any of the disorders in the neurodevelopmental disorders diagnostic class. The unspecified attention deficit hyperactivity disorder category is used in situations in which the clinician chooses not to specify the reason that the criteria are not met for attention deficit disorder for a specific neurodevelopmental disorder, and includes presentations in which there is insufficient information to make a specific diagnosis. So if you can't make the diagnosis, you could still make the diagnosis. This is still something that's billed by insurance companies. 31401, unspecified ADHD. You could still diagnose a kid with ADHD even if they don't meet the criteria. So it's just an absolute systemic problem. It's terrible. ADHD most of the time is pejorative. Most of the time it's just a kid with a personality type that's not conducive to the environment that they're in. And there are times where it is caused by neurotoxins, and there are times where it is caused by diet, and there are times when it's caused by, environmental factors such as scrolling TikTok too much or constant dopamine uh, consumption. So you really need to look at the individual when you're talking about why a kid may be disruptive in class, et cetera, et cetera. Maybe it's the environment, maybe there is an underlying cause to a condition, but that's why getting that back to the individual is the most important thing that you can do for these children. Let me know down in the comments if you like these kind of videos. We'll delve more into the science behind ADHD, especially the genetic factors being a complete fallacy. We can also delve into the environmental factors. We could delve into the studies surrounding that. Red 40 is a big one that they talk about. The evidence for it is sort of slim, and it's kind of difficult to talk about generally because it's not going to be the main cause of ADHD. But at the end of the day, it's the most important thing to stress is that ADHD is not a disorder. Although there may be times where if it is environmentally based, I still wouldn't say that it's a disorder. Um, I would say that there's something in the child's environment that is not conducive for them as a child, and we need to address the environment. We need to address the terrain. We should not be addressing this from the pharmaceutical standpoint. We'll look into that as well to see if it improves outcomes, but really it's just numbing personality, in my opinion. and it's just more conducive to what the teacher wants, more conducive to what the parents want, and it's not looking after the individual, it's not looking after the child. So there are causes to things, and I love how Andrew Coffin puts it. We should talk about these things as what causes them and not as what the manifestation is, because it will give us a better ability to aid that individual and do our best in maximizing our lives. If you like this video, like, share, comment, subscribe because we're giving a book away to 1,000 subscribers, The Structure of Scientific Revolutions. Please let me know what you thought about this video. I'd love to make more. If you want different mental disorders, there are no disorders, there are no mental disorders especially. All right, guys, thanks for listening. Take care.